this one was kind of straight out of the first few slides. So what is the definition of neutropenia? Anyone want to chime in?
Less than 500.
Yeah. So this one should be pretty straightforward. This is like must know kind of information. And then I tried not to put too many calculations on this IRAP, but there are a lot more if you've already seen the application. So what was this patient's ANC?
400.
That's correct. So there's multiple different ways to calculate the ANC, and you're going to practice each of them if you haven't already during the application. So we won't spend a lot of time here. And then last thing you're definitely going to need to know in terms of the exam is low risk versus high risk MASC score. So you can determine kind of where and how the patient needs to be treated. It's one of many possible tools, and it's kind of follow your hospital policies and procedures if that's what they use, though I would say it's pretty widely adopted. So 25, is that low risk, high risk, moderate risk, or no risk?
Low.
Low, correct. What's the cutoff number?
21.
All right, I think we can move on to question 4. So I spent a little bit of time talking about this in the video. So what's present day time, so 2020, what's the most common bacterial pathogen in cases of febrile neutropenia?
Positive.
Positive, correct. Back in the day, what was the most common?
Negative.
Negative, right. So we've seen a big shift in the last 30 or so years towards gram-positive. And last but not least for me, for patients who had low risk of febrile neutropenia, which of the following antimicrobials would be the most appropriate?
Levofloxacin.
So of the class, what are the appropriate quinolones?
Cipro and Levo.
Cipro and Levo.
Correct. No moxie, no gadafloxacin, no gemifloxacin, delafloxacin, just Cipro and Levo have been studied. So those are the only appropriate ones. What's an alternative beta-lactam?
Clinda.
Clinda. What else?
Glinda.
Not Clinda. What else? Early penicillin, neighbor, combo product. Augmentin, correct.
Oh, I thought you meant with lactam allergy. Never mind.
No. Alternative beta-lactam class that you could use. Yeah, so you got Cipro, Levo, Augmentin, and Clinda are your options for outpatients antimicrobial therapy.
Hey, real quick,
Yeah.
Did you say on there you were using the fluoroquinolone with the Augmentin?
No.
Oh, I thought it was plus.
No, separate. So
I got to.
Oh, sorry. No, yeah, either one of the quinolones or Augmentin or Clinda. So you'd look at like patient allergies, renal function, risk factors, and make a decision about which one of those would be used for your prophylaxis treatment. Make sense? Everyone on the same page?
Sweet. All right.
Yes, now.
Yay. Okay, so moving on. And I'm sorry, they're weed whacking in the background. Apparently, they weed whack pretty much every day here, so I apologize for the noise. So for patients accidentally exposed to non-therapeutic levels of radiation, blank can be used to prevent death from severe hematopoietic toxicity. So which of these do you guys think?
Dargramostim.
That's right. And what kind of drug is that?
GM-CSF.
Yeah.
That's right. Exactly. Now for filgrastim and tibofilgrastim, what drugs are those?
GCSF.
GC.
Right. Exactly. So for GCSFs, do we tend to use them for treatment of neutropenia?
No.
No.
So which of the drugs do we use for treatment of neutropenia for patients who are really in a high risk of having complications due to an infection?
The GM-CSF.
Exactly. And that's really kind of what I want you to take away from this, because there are times where physicians especially they kind of forget that leukine exists, and they want to go for, someone's very neutropenic in the hospital and they have a risk of a complication from an infection, and their go-to is like, oh, well, why don't we give them Neupogen? Well, that's because it's not indicated for that. We actually have a drug that helps differentiate multiple arms of, white blood cells in order to help deal with a potential infection. All right, so for the next one, Jo, wow, maybe he's an OG. Jo is a 22-year-old patient receiving intensive chemotherapy for testicular cancer. Jo has complained of severe bone pain after receiving his first dose of pegfilgrastim. What is the the brand for pegfilgrastim?
Neulasta or Onpro.
Neulasta, right. What kind of forms does it come in, or formulations? We talked about 2. So Neulasta is one of the brand names. What's the other brand name?
Onpro.
That's right. And what's the difference between Onpro and Neulasta?
Onpro is like a device that has like microneedles that injects the drug after a certain amount of time.
Exactly. And do you know how many hours after? Like, is it right after chemotherapy or?
Like 72. Or 27, sorry. 27.
27 hours, exactly. And why don't we inject Neulasta or any of these drugs less than 24 hours after chemotherapy?
Because chemotherapy can kill the baby neutrophils.
Sorry, say that again.
Because high concentration of chemotherapeutic agent in patient might kill the new neutrophils that are produced by this medication.
Exactly. And, I kind of talked a little bit about how this is sort of a controversial subject. And there are some clinicians right now who are trying to push for giving Neupogen Neulasta same day. But the previous evidence that we had from years ago really did show that there was an increased risk of severe neutropenia and prolonged neutropenia in those patients where we didn't wait. So in general, we don't want to do that. All right. So answering the question, what can we do for a patient? Like, what's the most appropriate recommendation to help prevent bone pain?
Claritin.
Claritin, right. What's the other name for Claritin?
Loratadine.
Loratadine. That's right. And when is appropriate to start Loratadine?
A day before.
Mm-hmm. And then a couple of days, right? 2 or 3 days after we give the injection. Now, I could have used cetirizine, right? There's nothing wrong with using any kind of antihistamine. It doesn't have to be a second generation. It can be a first generation. The reason why we tend to avoid the first generation antihistamines is because they're very anticholinergic. And, there's a higher likelihood that patients will be really sedated. They might have like a lot more dry mouth, just kind of some of the discomfort from having a first generation. You can actually combine another antihistamine with cetirizine or loratadine. Which antihistamine do you think that would be that? And it might not come to you right away, but there are other antihistamines that we can use. Any takers?
You use Benadryl?
Well, we wouldn't combine those two kinds of antihistamines, but there's another class of antihistamines that we don't really think of as antihistamines, but they are.
You're talking about the stomach ones, brain farting.
That's right, exactly. That's like my favorite drug. So it's cheap, it works. So yeah, if we want to block that histamine pathway that helps result in the bone pain, probably from the expansion of mast cells and the actual migration of these new cells outside of the bone marrow into the periphery, that's really what causes the pain. So antihistamines are really effective in shutting down some of that pain that can occur. We also, and I didn't want to confuse things, but normally what I do is I recommend like a 3-drug combo for patients. So I'll say, take a loratadine plus a Pepcid, same schedule. So take them together, start the day before, do them a couple days after. And then additionally, Tylenol is very helpful for bone pain as well. It's just not quite as effective as the loratadine and other antihistamines for stopping the bone pain. So just keep that in mind. If when you first recommend loratadine and the patient's like, yeah, it helped a little bit, but not enough, you can start combining other drugs. All right. Any questions about that? Hang on. Okay. Oh, thank you. Sorry, my breakfast just arrived. Okay. So next question. A high-risk regimen has a greater than 20% incidence of causing febrile neutropenia. True or false?
True.
Excellent. All right. So just really fast, remember when I gave you the lecture, I talked about the differences between neutropenia and febrile neutropenia, right? So when I categorize a regimen based on risk, and this is going to come in really handy when you do the application, while it's important to know how often neutropenia itself without a fever occurs in a regimen, the number that we actually pay attention to is the percentage of patients who experienced febrile neutropenia. Now, sometimes in a publication, they'll do something stupid, like, especially the older ones, they'll talk about grade 3 infections. So they'll kind of say, all right, well, these patients experience neutropenia, and then these patients experience grade 3 infections or higher. And the problem is that febrile neutropenia and infections are not necessarily, they don't necessarily go hand in hand. You can have no pathogen growing out in a patient who's both febrile and neutropenic. And so, one of the reasons why we treat prophylactically, as Dr. Fox talked about, when that happens, is we want to make sure that nothing does develop when someone is kind of their immune system is at the lowest point. So when you do the application later, I really want you to focus on, okay, what's the incidence of febrile neutropenia? Because that is something that could require hospitalization or treatment. And if you can't figure out what the rate of febrile neutropenia was in a study, look to see what the severe infections were, because again, often they'll correlate. Does that make sense? Cool. Okay, a common ADR that you expect a patient to experience while receiving a GCSF. Any
Bone
take?
pain.
That's right. That's right, bone pain. So splenic rupture is a awful ADR that can happen, but it's pretty rare. I mean, we're talking probably less than 1%. Headache isn't really super common. I mean, any drug can cause a headache, and unfortunately, after patients have chemotherapy and they have these injections, it's hard to know what's causing the side effects. But we do know that bone pain is common and occurs in, I think it said more than 25% of patients in the slide. It actually occurs in basically 100% of patients, just to varying degrees of severity. Hypersensitivity reaction, we don't expect that. It can happen. Usually it's more of a localized skin reaction. All right, so let's go through the last question, and then we'll get ready to break out into our rooms. Your patient is going to be receiving a regimen that has a 15% risk of febrile neutropenia. So first of all, what is a 15% risk regimen? Would that be considered high, intermediate, or low?
Intermediate.
Exactly, right? So between 10 and 20%. So he will continue on the regimen for approximately 6 months unless he experiences unacceptable toxicities or progression, right? So if he's not able to tolerate the chemo or if his cancer gets worse. For approximately 6 months, oh yeah, I said that, okay. So your patient is 75 years old and has diabetes. So those are already 2 risk factors, right? So the patient is older, which means that his immune system is probably more likely to be impaired. And he has diabetes, which we know increases your risk of infection. We don't know if he's got uncontrolled diabetes, but it doesn't really matter. We know that he's got 2 risk factors already. based on your patient and the regimen, what is the most appropriate action to take? So what do you guys think about this? And this was meant to be a harder question because I want you to really work through or reason through what you should do. Any takers? So I don't have to call on anyone.
I was thinking that we would give him a GCSF for the first cycle.
That's right. And tell me a little bit about why.
Well, he's one of the high-risk populations, so it's recommended to give that to him.
Exactly. And he also has an intermediate risk regimen, right? So when we see a high-risk regimen, we think immediately we're going to prophylax. It doesn't matter if you have a risk factor or not. We know that this regimen has a high risk of causing febrile neutropenia, so we're just going to give it to you. That's an easy one. When you get into intermediate, that's where things become a little bit more complicated. And you have to really consider, do I wait until someone has had febrile neutropenia? So if he hadn't been 75 years of age and have diabetes, let's say he's 35, right? And he's got an intermediate risk regimen. As long as he's otherwise healthy, I probably would just wait until he fails. I mean, that sounds terrible to say, but we don't necessarily think that he'll need a prophylactic GCSF starting with cycle 1. And in that case, I would say, all right, if he fails after a couple of cycles, whatever, we'll just add it on for subsequent cycles. But in this case, we know that if this patient ended up with with febrile neutropenia, there's a possibility, a very high possibility, that he would have serious complications. And, again, we want to keep patients on track with their therapy as much as we can, even if it's palliative, because oftentimes we're giving palliative care chemotherapy to reduce the symptoms of cancer. We're not trying to cure them, but we want patients to be as comfortable as possible for as long as possible. So how did everybody feel about that? Do you have any questions, or does that make sense?
So, just to confirm, since this patient does have risk factors, it would be appropriate to give it with the first cycle.
Yes.
However, if the patient is healthy, according to the guidelines as well, it would be more appropriate just to wait till they develop febrile neutropenia and then treat it from there.
Exactly. Okay. Because the thing is, the more drugs. This isn't like anti-emesis, right? Where the drugs that we're working with, like Zofran and NK1 receptor antagonists, those are pretty safe drugs. I mean, of course, every drug has a risk, but anytime you're trying to mobilize, white blood cells, there's always a risk of having something serious happen, like a splenic rupture. And even though it's rare, it can happen. And there are some potentially other problems associated with giving GCSF. So one of the things we do know is that when we give GCSFs for high intensity chemotherapy for patients, especially patients, for example, who had breast cancer, there does seem to be an increased risk of myelodysplastic syndrome. Now, we don't know if that's just related to the chemotherapy doing a lot of DNA damage to the bone marrow, but we do think that there's probably a correlation of giving a medication that allows for the proliferation of white blood cells. And so, again, we want to be a little bit more judicious when we use these, as opposed to, supportive care, like giving somebody a transfusion. Those are fairly safe for anemia, or giving somebody, an olanzapine or something like that for anti-emesis. So does that make sense? Cool.
Yeah. Excuse me. I just have input. I think we give it after we assess for the risk, not after the incident.
So we do both, right? So we assess the risk for the patient up front. And in this case, I'm assessing that even though his regimen is intermediate risk, that he himself is a high risk. So that's why I'm making the decision to give it before we have him actually have a febrile neutropenic incident. Okay, but if this were a high-risk regimen, you're right, we would have just given it automatically. Or if he didn't have risk factors, then I would wait and I would assess after the first cycle to see how he did. Does that make sense? Because I mean, I can see how, you know, when you're looking at all the algorithms, it can seem a little bit confusing, especially since in the guidelines, the list of high risk and intermediate risk regimens, it's not exhaustive. So there are a lot of regimens out there that, you know, we kind of have to just figure out, well, what's the risk associated with this, and then make a decision. Okay, cool. All right, Dr. Fox, do you have anything else to add?
I misgraded one of the questions. I had selected the wrong answer as the correct answer, so I changed that already and updated it. So some of you guys may have seen a bump already.
Yay! Excellent. All right. So here's what I'm going to do. I'm going to have everybody take like a 5-10 minute break, just because John Breyer is going to come back on and we're going to try and break you out into your groups. So when you arrive back, you may find yourself in your breakout group, hopefully. If not, we'll just do our normal plan. Fingers and toes crossed. So we'll try and do that. If that doesn't work, we'll just do our normal plan. Sound good? Excellent. All right. And Dr. Fox, I'll be right back.
Sounds good. I'll be here.
Yay!
Look, come here, sit.
Hi, Toby.
Who's that?
Toby, it's your favorite aunt.
Is that a
Hi.
Boston Terrier?
Yes, it is.
Did you purchase any other dog from where you're from?
No, not yet. Eventually, I'll have to replace this one, sadly. So
Cover his ears.
I know. Look how great he is.
He's a great dog. He's also like freakishly tall for a Boston.
Yeah, he's a really big boy.
You are so cute. Hi, Toby. I miss you.
I know.
Physical distancing stops.
Boston Terrier.
Come face this way. That's your bad side. Come here.
Just like Mariah Carey. I forgot about that.
Yeah.
All right. So, John, I think I see you there. Maybe we can try and break everybody out. Oh,
So go ahead and do the recreate.
okay. All right, recreate, and then recreate all rooms. Got it. And it says assign 74 participants into 3 rooms. So it's got to be 13 rooms. And then automatically or manually?
That should be all you need to do, and just get out of that screen.
Yeah, no, it says automatically or manually.
Automatically.
Okay. All right, open all rooms. That looks like it's working. Maybe.
You may have redone it.
And it's saying close in 50 seconds. Sorry. It's going to take a minute.
That's okay.
It's all right. I'll keep eating my omelet while I... Darn it.
Did you mean to pull it back?
Yeah.
Yeah, we're it's a little glitchy. We're working on it. Okay. So John, that didn't work.
So pre-assignment, don't hit automatic.